Record to cloud. All right, now we're recording. All right, so if you're watching this at a later date on YouTube, remember to do the quiz on vinyl so you get your distributive Con Ed. And we'll put a link to that at the end here. So these ventilated transfers are ones that we can actually make a difference, and we have to be active in the process. It's not something that we can copy over from the physician. And same thing on your EMTALA form. It's something that we want to have the ability to change our sedation, titrate to effect. And that's how it should be with any presser you have. When I had Rachel Lanson with me yesterday and we had a patient going on a presser, it was a good education point that don't just take them on a set rate, make sure it's titrate to a map of greater than 65. And the same thing with your vent settings, titrate to effect. It's really important that we do that, and we're being an active and educated clinician in this process. So I'm going to share the screen to the PowerPoint here. Everyone can see that okay? That pop up? Yeah, cool. So I understand that even in my paramedic education, in the initial schooling, we didn't go over ventilators. And when you suddenly go into an environment where you're using them, it can be a daunting task. And I understand that, and I appreciate that, because it's a high acuity and a low frequency skill, similar to intubation. And when we're doing this, we need to be sharp with it, and we need to be doing things efficiently and appropriately. So because of that, we developed the CQI module where now we can pull all of our ventilated transfers so we can keep an eye on things, and make sure, one of the big things for me is and Evelyn and a lot of you guys can attest to this, that when we go to facilities, one of the things that they're really poor about is actually treating the patient's pain. I'm constantly having to ask for an adjunct for pain management, asking for fentanyl boluses en route, because it's painful to have a tube put down your throat and being breathed for with a mechanical ventilator. And just because the patient's sedated does not mean that their pain's being managed. So if we can pull these reports and I can have some data that shows, when our paramedics are showing up at the facility, they're needing to ask for different sedation, or they're needing to ask for a pain management option, or they're needing to ask for different vent settings. This is all stuff that we can kind of pull together. So it's really important that when you do your TEMSIS, some of you are really good about it. Others might not know that this exists. There's a procedure that's under respiratory. It's a ventilator care and adjustment that if you don't do that, we can't see the vent call. So, don't try to get away with it if you don't want us to see your report, and just don't do this. We need you to do it so we can get the data. And that's really important. Some of the questions that we're looking at in this vent CQI module, just so you're aware of, it will help us with the documentation. And we're going to try to stay on top of this. I've been looking at a lot of the vent calls since we've gotten it up. In case you forget, I can ask you while it's still fresh in your mind. I want to know if our vent was used, or if you took the hospital vent. Did you use a HEPA filter? Did you need to change the sedation agent? Did you need to ask for pain meds? Did you need to ask for the vent settings to be allowed to be titratable? And additionally, one thing that I'm just a little bit curious about was if you clamped the ET tube when you're transferring onto our vent. And that's something that we'll go over when we talk about vent settings specifically.
Bobby, I have a question.
Yes.
So with the things that you guys want put into TEMSIS, can you create just a worksheet so that it prompts us? I'll be honest, I'm gonna be like, yeah, I changed it. I'm not even gonna probably tell you what I changed it to. You know what I mean?
I'm working on an electronic worksheet that we can use for PCSs or for it's within TEMSIS. It would be off to the right hand side like a widget. I'm working with Chip right now to figure out what we can do to help along with this. Right, and then it automatically puts stuff into your report when you use the widget.
Right, but what I'm saying is it's just a piece of paper that we can handwrite some notes, so that when we do get the chance to sit down and do our reports, that we can be referenced to that.
Yeah, I think the vent transfer sheets that we have. that should tick most of the boxes. Sometimes people don't do them, but if you write that out and then you scan that in, we can pull that off of CQI, and that will, at the least give us our vent settings, which I'm curious about. And, the pharmacology side of it, you would have documented that like you normally would in your report. So we'll see that just fine. I guess the only thing that I'd like documented, if you can remember it in your narrative, is if our vent was used, would be that's kind of one of the things that we're looking more into. And, the reason being, we take patients from smaller critical access hospitals that, especially at night, they only have one RT on, and we have ventilators on our trucks with the purpose that we should be using them. And I understand in the emergent setting and you want to get people out fast, then that's different. But the patient that's been intubated for 4 or 5 hours, you get that at 3 a.m, and there's only one RT on, you should be able to handle that and take whoever they give you, whether it's the tech or the nurse. But we're trying to avoid it, because hospitals are starting to become sometimes frustrated when we pull their only respiratory therapist and take them to Dartmouth and they're gone for a couple hours. That's just it puts them in a tough spot, and we have our own ventilators for that reason. So, all right.
There's
So-
a new and old vent sheet that I've seen that's still floating around. There's the old one that's not really, that streamline is missing a couple of values, but there's a new one that I think that Evelyn sent out or somebody sent out like a year
Yeah,
or two
I
ago.
think
That's nice.
we'd like to do, and we'll talk maybe a little bit at the end, especially in regards to proper vent settings and rates and stuff. Maybe we just look at creating a new vent sheet that has everything we want on the CQI module, and then you can just check all that off and scan it in, and we'll have everything we need. Would that be a reasonable solution for people? Would that maybe make it a bit easier? And then exactly what to check, and then it streamlines everything that I kind of want and need. So we're going to do the overview of the night. I'll try to keep it short but efficient. When it comes to training, I don't like having my time wasted, so I try not to waste other people's times. I want you to be able to take something out of this, and a lot of it might be review for you, but this might be new to some people as well. And so we're going to kind of go over just general pharmacology, so our paralytics and our sedatives, as well as just fentanyl for pain management, what our vent settings look like, so what we should be seeing, hopefully the sending facility doing, but if not, what we should be looking at changing and what changing it to what. And then we're going to go over our non-positive pressure ventilation, because a lot of people are unfamiliar with how CPAP and BiPAP works on the LTV1200. The LTV1200 is a great transport ventilator. However, it's not the most user-friendly. So hopefully we can clarify a lot of this tonight. This isn't, a generic vent lecture. I tried to build it in a way that it is specific to our vents and the transports that we do, to just get people more comfortable, and just a bit of a refresher for people who are comfortable. So I made a short video of just setting up the vent and calculating settings. So we'll go through that as well. We'll go over alarms and just three cases that will hammer home just some of the critical points that we're going over tonight. So I'm going to go over 4 different paralytics. The one that people are going to be most familiar with is succinylcholine. Probably that's what you learn in paramedic school. That's what most older doctors all the time. It's, your RSI is succinylcholine. Out of the 4 that we're going to go over, it's the only depolarizing agent. So hint, hint for the vinyl quiz, it is the only depolarizing agent. It was initially preferable because it has a very fast onset time and it has a short duration. So out of the other, this is the shortest half-life out of all the other paralytics. And that made people feel a bit more comfortable, because if you're paralyzing a patient and then you can't get an airway, then the paralytic's going to wear off. Realistically, that shouldn't matter, because anytime we're putting in an airway, we have to have a failed airway algorithm, and not securing an airway with paralytic will be part of that algorithm. So if you don't get first pass, what are you changing in your second attempt? Are you changing positioning? Are you changing your equipment? Are you adding a bougie? If do you need to put in a supraglottic airway? Can you not ventilate him through that? And do you need to do a surgical airway? All these things come into play. So it shouldn't matter really the half-life of succinylcholine, because it actually can be a really dangerous paralytic. So when we look at how succinylcholine actually works, don't be scared by the anatomy diagram here, but it works off of our action potential. It's a neuromuscular blocker. And so it's non-competitive. So when we have a stimulus for action potential, what happens is we get an impulse and there's an influx of calcium. So everything in our body and impulses work off of that electrical gradient. So that influx of calcium stimulates this release of acetylcholine. So you can see it moving through the synaptic gap right there, across the nerve terminal into the muscle, and then it binds to these nicotinic receptors. When that happens, it creates a conformational change in the ion channels. And all it's doing, so if you see in your bottom left there, initially there's a net negative charge in the muscle. It's the same thing as how the heart works. When that channel opens, so when the acetylcholine binds to those receptors, you're going to get an influx of sodium and an efflux of potassium. And this is exactly how our cardiac cycle works as well, because the heart's the muscle as well, right? So that positive charge is the depolarization, and that's how we get our muscle stimulus. So succinylcholine, the molecule is very similar to acetylcholine, and what this essentially does is it holds that ion channel open and it causes a sustained depolarization. So this is dangerous for a couple of reasons. So succinylcholine is the only paralytic that's going to cause fasciculations, and fasciculations are basically twitching. So that's how if you remember doing your OR time, and the anesthesiologist, if they're using sucks as their initial paralytic, they'll check the twitching. They know that the paralytic's working, and then they'll continue on with the procedure. But what they're finding, especially in some newer studies, is when you think about what twitching is doing, it's widespread muscle contraction. That's going to massively increase your oxygen demand. So compared to non-depolarizing paralytics like ROC and VEC, they're finding that the time to hypoxia with succinylcholine is actually about like 90 seconds faster. So it's a bit more damaging from that aspect. But the bigger harm for it, especially in the pre-hospital setting where we can't obtain lab values, is you have this huge increase in serum potassium, because you can see in that open ion channel, it's holding it open. So this is really dangerous, and anything where you could suspect hyperkalemia. So our burn patients, our crush injuries, hyperthermia, newer onset DKA, any cardiac arrhythmias, succinylcholine can be very damaging to those patients. So, there are more and better options with our non-depolarizing paralytics like rocuronium. So rocuronium works competitively at the nicotinic receptor. So what it does is it blocks that channel from opening, so there's no receptor depolarization, so you're not going to get fasciculations, you're not going to get that potassium released into the serum. So there's less risks for severe side effects. And rocuronium is an agent that we can use on a transfer in situations where we're looking at the half-life there, so 30 to 60 minutes. If we have a patient that's non-compliant to the vent and you're more maxed out on your pain management, because when we think of reasons that patient would be non-vent compliant, are the settings off? Are they not sedated enough? Are they hypotensive, so their sedation is kind of maxed out as well? It's not unreasonable to ask for a bolus of rocuronium that would get you to Lakes to Concord, Spear to Concord. With that, generally it'll last for about 45 minutes, and it will help make the patient tolerate the vent on the way for that transport till they can adjunct them to whatever pharmacological package, or realistically, they're going to change the mode of the ventilator in the ICU. The other thing with non-depolarizing paralytics is there's a reversal agent. So if there is a complication where you need to get rid of the paralysis, a medication called sugamatics, which the best analogy is it's like a Narcan for paralytics in a way. The difference is that it's not pushing it off, it just encapsulates the molecule. The only downside to using a reversal agent for a non-depolarizing paralytic is it stays in the serum for a lot longer, so you then can't reparalyze them with a non-depolarizing paralytic for 24 hours if you need to reattempt or reparalyze. Vecuronium is very similar to rock. However, it's a bit slower of an onset. It's still non-depolarizing. You're more likely to see this as a continuous infusion. You're more likely to see it in the pediatric population. It's smaller dosing, so it's more titratable. There's not really too much to go over with that, though. Cisatracurium, the other name for its Nimbex, to be honest, this is in here because I'm a nerd. I had read and learned a bit more about this recently. The thing that's really interesting about it, it's not used as commonly because it's a much slower onset. It's great for sustained paralysis in really sick patients, especially pediatrics, because of the way that it's eliminated from the body. Because in any medication that we give, we're more concerned if they have renal or hepatic impairment, just because that's going to affect the metabolism and how it's excreted from the body. Nimbex is really cool because it's actually eliminated by a chemical degradation in the plasma. So it's a lot safer in your, acute renal failure, cirrhosis, things like that. So I thought that was kind of a cool thing. For sedation, we're just going to go over 3 drugs. The propofol and ketamine are generally going to be the most common drugs that we're going to see on our continuous infusions, on our ventilated transfers. And this is kind of one of the issues that we're running into, really, and why I'm more curious about this CQI module, because I'm often having to ask for a change in the sedation package. Because oftentimes you'll go into Huggins or you'll go into Lakes or Spear, and they're going to be on a propofol drip, and they're going to be mildly hypotensive, and they're not going to be tolerating the vent, and they've kind of maxed out their propofol, and their solution is to give them Versed, which is also going to affect their hemodynamics. When in reality, if there's not a contraindication, I'll generally always ask for ketamine. Propofol is great in the hospital setting. It's a combination of a sodium channel blocker and a benzodiazepine. So, you get that effect of a GABA agonist. So it's basically works in the effect of an inhibitory neurotransmitter. The issues with it is that you're seeing a decrease in your systemic vascular resistance. So it's affecting your blood pressure. In conjunction with the decrease in contractility, you're going to get a decrease in cerebral blood flow, and it's going to decrease your respiratory drive and your airway reflexes. So it really puts people down. It does wear off relatively fast, but in your really sick patients that are hypotensive, this is just not a great sedative to use, and there are better options. The other thing to note, really importantly with propofol, and it's an issue that I see with hospital staff relatively frequently, is because they're so sedated on propofol, they don't manage the patient's pain. And just because someone's sedated does not mean that their pain is being taken care of. And that's a really important concept that I want people to take away from tonight. Ketamine, people who know me know that I love ketamine. I think it's a phenomenal medication. It's very versatile. It has a very safe cardiovascular risk profile, meaning that it's not going to drop their blood pressure. It's not going to decrease the respiratory drive. Ketamine's really neat because it has this basement effect. So it's not like, if you snow someone with Versed, you're going to take away their respiratory drive. If you snow someone with ketamine, it's just going to prolong the effect of it. So it's going to continue working. Ketamine needs to be dosed properly because you get into trouble when you're in that in-between phase where you hear these horror stories of, reemergence phenomenon. And that's because the way that ketamine works is it blocks NMDA receptors. So it's working on your thalamic and your limbic systems, and that's what's controlling your sensation, your perception, emotion, memory. So to be Zoom appropriate, like it can really screw you up if you're misdosed on ketamine. People are going to have a bad time. The proper dosing for sedation, it works really well in these patients, especially because one of the other kind of beneficial effects of ketamine is a patient that is being intubated for an underlying respiratory pathology, it works as a bronchodilator as well. So you're kind of getting an additional effect there. Our cautions with ketamine are head injuries, because you can get a reflex hypertension. There is some bit of hypersalivation that's seen more commonly in pediatrics, and the solution that they generally do is they pre-treat with a small dose of atropine. It's usually 0.02 mg per kg. And the other more scary one, it's seen not very commonly, but you will get sometimes a laryngospasm. And another hint for your vinyl quiz, if you push ketamine too fast, that's when you more commonly see this laryngospasm. There have been some neat studies of how to get rid of it. There's something called Larson's maneuver, and it's basically like a modified jaw thrust. So say you walk into an ED, and Evelyn's pointing an arrow at something. Sorry. So if you walk into an ED and they're freaking out because the patient has their cords closed after they push ketamine, if you suggest Larson's maneuver, and it might really save the patient. But it works basically on these pressure points in the submandibular area. That's why the easiest way to describe it is almost like a modified jaw thrust in a way, and it can help alleviate that pressure and reduce the laryngospasm. So it's pretty neat from that point. Otherwise, ketamine is a very safe drug. It's very hemodynamically stable, and it's not going to affect your respiratory drive. So it's very safe as a transfer sedative. Etomidate, we'll go over very briefly. Again, similar to propofol, there's no analgesic properties. So, they still need pain management with this. And even with ketamine, the jury's kind of out at that dose. Is it treating their pain? Is it not? Even if it's not as much, it's still treating the pain better than propofol and etomidate will. So you're not going to be faulted at all for adjuncting ketamine with fentanyl. Etomidate and propofol definitely need some sort of analgesia with it. Etomidate seen more commonly is just the induction agent for RSI. Really quick onset, short duration. So a common package that's seen in the ED is they'll be intubated with succinate etomidate or rock and etomidate. And then they'll be put on propofol. A lot of the younger physicians or people who are keeping more up with current critical care practice docs, you're seeing rock and ketamine, basically. The concern with etomidate, again, is it's decreasing respiratory drive and airway reflexes. It is a great sedative in your TBI or stroke patients because it's one of the only sedatives that will help. It will decrease your ICP, but it will maintain a normal arterial pressure. So that's one thing to keep in mind, where it's a little bit better than ketamine. But the concern as well is that it suppresses your corticosteroid production. So it causes an adrenal suppression. So it's really not the best adjunct if you're intubating the patient secondary to a sepsis pathology. But pain management, if you can take one thing away from tonight, please make sure that on your ventilated transfers that you have an order for fentanyl. During this, intubation and mechanical ventilation is extremely painful and it's stressful on the patient's overall physiology. And if a doctor tells you that they're worried about their blood pressure, fentanyl is very hemodynamically stable. There's no reason that the intubated patient shouldn't get fentanyl. In the ORs, anesthesiologists and CRNAs are often sometimes using fentanyl as the primary sedative. They're giving it 700 to 900 micrograms IV push. And that works for them. And it's better with fragile hearts or left ventricular dysfunction. And that's why they do that. And, smaller doses more frequently work great just because of the synergism and the effect with the other drugs in the body. So, depending on the patient's response, we see pain in the sedated patient based on, are they compliant with the vent? So are they over breathing? Are the airway pressures high? Are they tachycardic? Or, more obviously, are they tearing in their eyes? How many times have you walked into an ED where the patient literally has tears in their eyes because they've been intubated for 2 hours and only received their initial propofol bolus in the infusion and no pain management? You really need to advocate for your patients from this manner. So there's to simplify vents down to the basics. There's two strategies. The one that we're primarily going to go over is lung injury. Lung injury covers everything that's not obstruction. It's kind of the broad term. And lung obstruction is our pathologies of asthma, COPD, emphysema, where there's, you know, a literal obstruction in our bronchial pathway. I highly recommend listening to MCRIT. So Scott Weingart, if you don't listen to him, he does some great podcasts on critical care and ED medicine. And his Dominating the Vent lecture, it was the primary basis of what I learned most about ventilators, and you can build off of that. But his podcast on Dominating the Vent was kind of the premise of this presentation tonight. So generally,
Sorry, Bobby.
yeah.
What was the name?
It's the podcast is MCRIT, EMCRIT. And the name of the podcast episode is Dominating the Vent. And it's like 28, 29 minutes. And he really breaks it down. He's a great speaker, and it covers all the concepts that you would need to manage your ventilator at, you know, in this AC setting.
The name of the speaker?
Scott Weingart. And I can put up a link to that as well. There's part 1, which goes over lung injury, and part 2 that goes over obstruction. If you're going to listen to one, listen to the.
Apparently, Nerd Alex has already done that.
Thank you. So most of our transfers are going to be in the assist control setting. So when in the video later, I'll show you where the modes are. I think you would already know where that is, but it's abbreviated AC. AC is great for the tired patient. It's a good adjunct setting to get them to whatever they need at definitive care in the ICU. Assist control works off of, you know, obviously of all your vent settings, but you set a rate and you set a tidal volume, and you're good to go, because they're going to get at a minimum that rate that you set. So if you set the respiratory rate to 16, no matter what, they will get 16 breaths. They might get more because they can trigger a breath. So if we see here where there's that red arrow and it's pointing to, you know, when we breathe, so we work over pressure system, so negative pressure, it will trigger the ventilator. And when it does that, in an assist control setting, they're going to get whatever the set tidal volume is. So in other ventilator settings, if they stimulate their own breath, so they call it a spontaneous breath, they might only get it at whatever they're breathing to. Say it's like 200 mLs, it's really shallow or something like that. If they're spontaneously breathing, they're going to get a full tidal volume breath at whatever you set it at, 480, 500, depending on their body weight. This becomes dangerous if they're not sedated enough, because you can understand why, that if they're not sedated enough and they're spontaneously breathing and you have a respiratory rate set at 16, but they're breathing 28 times a minute, they're going to be receiving way too high of a minute ventilation. So, you know, we can see that if we have our respiratory rate set to 16, but we look at either our monitor, you know, on a respiratory lead or end tidal, or on the vent itself, it will have the number F, or it will have the letter F, which stands for frequency. So that's how many times the patient's actually breathing. If you see that they're over breathing at that rate, they need more sedation or they need pain control. And that's really important to recognize. Otherwise, they're going to get, you know, an egregious amount of tidal volume. That being said, it's really good for those weak respiratory muscles. If they've had built up lactic acid or CO2, this is really helping them relax, and you're doing all of the work for them on this ventilator setting. One of the pitfalls of this is that in the ambulance, you can cause an accidental hyperventilation because there's a trigger sensor on this. So the bumps in the road and the movement, that can cause the ventilator to think that the patient's spontaneously breathing when they're not. So that's something to be aware of as well, that you might need to increase the trigger so you're not getting this air trapping issue. So there's a billion buttons on the vent. there are really four main concepts that I want to go over. That's our tidal volume, our respiratory rate, our flow rate, and then our FiO2 and our PEEP work in conjunction. If you don't remember any of the other settings, it doesn't matter. And that's what Dr. Weingart talks about in his Dominating the Vent lecture. You know, these are the kind of the big take-home points. Historically, patients have received way too high of tidal volumes. We've gotten a lot better at that now. But when you think about kind of our lung pathologies, if there's already damaged alveoli and we think of our lungs as a container, then there's a notification. Sorry, I'm not that much of a nerd that I'm good with computers as well. So I'm trying to admit people into the talk as well. It's Nick though, so we'll see how much he takes away from this. So the tidal volume is, you know, really important because it's what protects our lungs. So if you're receiving too high of a tidal volume in a scenario where we already have damaged alveoli and our lungs are a contained space, then all of that tidal volume, especially if it's really high, is going to go to our good healthy alveoli, and that can secondarily damage them as well. So we look at 4 to 8 cc's per kg. Generally starting at 6 is pretty normal because then we can move up or down depending on airway pressures and things like that. But we're doing that off of our ideal body weight, which is really important because this helps us avoid that kind of, you know, the Michelin Man scenario where, say you have, you know, the 5'2", 300-pound patient, they don't need 300 pounds worth of tidal volume. That would be very damaging to them. And unfortunately, most of the patients that we have are going to be heavier. So it's not going to be their actual weight. It's going to be their ideal body weight. And that calculation is actually in our protocol book. And it's right here. So it's slightly different for males than females. And I can't see the chat, but I put 2 examples if you guys want to try to calculate the ideal body weight based off that formula. So the female that is 5'8", but 175 pounds, and we kind of walk through it here. So they're 68 inches tall, right? So 68 minus 60 is 8. You multiply that times 2.3. And then you add that to 45.5. So their ideal body weight should be 64 kilograms. If you did that based off of their actual weight, you'd have them at 79.5 kilos. So that's actually a pretty significant difference. And it's the same thing with the male. Their ideal body weight is going to be 80 kilograms off of their actual body weight, which is 95.5. So that becomes pretty significant when we're calculating our tidal volumes and we're trying to use these lung protective strategies because we don't want to overventilate them. And that's a really important concept. So to reiterate, our tidal volume, we're starting at 6 cc's per kg of their ideal body weight. So whatever their ideal body weight is, multiply that by 6, and that should be your starting tidal volume, okay, in the basic AC mode patient. We're going to be changing our tidal volumes based off of airway pressures. The plateau pressure is the most important pressure for pulmonary compliance. Unfortunately, on most ventilators, especially, you know, even the LTV1200, it's not the easiest thing to do a plateau pressure because there's not a button that says plateau pressure. So I'll go over how to take one. And if you document so plateau pressure is a P-plat. It's called P-plat. If you document a P-plat in your narrative, I will buy you a Dunkin' Donuts gift card. Like, I think it is that important. This isn't Stacy's money or Stuart's money. If I'm CQIing your vent report and you have a documented P-plat, I will buy you a Dunkin' Donuts gift card. Because this is a direct reflection of the alveolar health. And this is where we're going to see our damage. The P-plat, if it's elevated, and we say anything elevated is greater than 30 centimeters of water, we need to start dropping our tidal volume. And that's going to really affect our patient comfort because the alveoli are going to be generally already classified pathology, so there's less space for the volume to go. So anything higher is going to damage them. And we need to be really careful with how we do that. Causes of an elevated P-plat can be decreased pulmonary compliance, vascular permeability, pulmonary edema, tension pneumo, ascites. Because if we start having these elevated airway pressures, it's going to overstretch the alveoli, and then that's going to set off a whole inflammatory cascade. So it's going to signal cytokines, and we're going to get this vascular permeability. It's going to damage the pneumocytes in the lungs. That's going to cause a decrease in surfactant. We're going to lose our PEEP, and it eventually leads to death. So it's really important that we're keeping our airway pressures low and under 30 on that P-plat. We check a P-plat by doing an inspiratory hold. And we can go over this whenever, if you're on shift. I highly recommend that after this presentation, your next shift, you go in and you play around with the vent. And you put the test lung on. It can be tricky checking a P-plat with the test lung, especially if you're not hooked up to the oxygen. You'll see it in the video, because if there's an alarm going off, it won't let you do it. But basically, you push this it says insp hold. You're going to push that once, and then as they're inhaling, you're going to hold it in. And when you hold it in on the window, it'll say P-plat, and it will give you a number. You'll also be able to see that on your bar graph as well. So if you see that, that's fine, but it'll actually give you the number as well on the LTV1200. And that's your plateau pressure. So if they have a plateau pressure of 35, which would be pretty bad, then we can change our tidal volume to maybe 5 cc's per kg. And then let them breathe a couple more times, check the plateau pressure again. And if it's still really high, then maybe drop them to 4. And ideally, if you're not going to want to go any lower than 4, because then we're really affecting our minute ventilation. So 4 cc's per kg is our lower threshold of tidal volume. But when it gets to that point, you just kind of need to leave them at that. And when they get to the ICU, they're going to put them on a pressure control setting, because that's the only way to really fix that solution, that scenario at that point. But plateau pressure is really, really important. So again, it's using that inspiratory hold button. You push it once to activate it, and then hold it in as they're breathing, and that will get you your number. Inspiratory flow rate is reflective of the patient's their comfort. So that's how fast a breath is being delivered. We actually don't have a flow rate button on the LTV1200. There's a calculation that it does in the background of the algorithms of the machine, and it'll pop up as VCalc. You'll see when you're looking at your ventilator and it's just toggling through, as on your normal transport, you'll see PIP, F, which is your respiratory tidal volume, and it's just these things that pop through, and then you'll see VCalc. That's your flow rate, and that's just based basically off your minute ventilation and your I time. So your I time, that's where you see, and you might have seen in reports, or you might have documented, that's your I to E ratio. So your inspiration to expiration ratio. So say you have them on a respiratory rate of 15. So 15 times a minute means that each breath is taking about 4 seconds. Does that make sense to everyone? 60 divided by 15 is 4. So each breath cycle is 4 seconds. So if their I time is 1, then that leaves 3 seconds for them to exhale, right? So their I to E ratio is 1 to 3, right? So we would need to change the flow rate, or how fast that breath is going in. If you saw something like if they were sucking on the tube, like they're not getting air fast enough, their flow rate is their comfort. If you're going to forget about a button, and Weingart says this as well, this is the one to forget. Not as important unless you notice that clear-cut sign of them sucking on the tube. In other modes of ventilation, it's a bit more important, but not as much in our AC setting. So our respiratory rate is something that we calculate, and we calculate it based off of our tidal volume and our minute ventilation. So when we're breathing right now, we're getting roughly 60 cc's per kilogram. That's our rough our minute ventilation. So 60 cc's per kg per minute. When we intubate a patient, what we're doing, because of that breathing tube, because of the vent circuit, we're massively increasing their amount of dead space. So we need to double what their minute ventilation is. So we calculate their minute ventilation, and then we divide that by our tidal volume to get our respiratory rate. Because when we think, it's the same thing when we are trying to see how much volume they're getting over a minute. It's how many times they're breathing and how much they're breathing with each breath, right? So it makes sense that to get the respiratory rate, we're going to divide that minute ventilation by the tidal volume. So there's 2 practice ones right there. If you guys want to calculate that out and someone wants to give it to me, that would be cool. And we'll say for the female, we'll do it off of their tidal volume of 7 cc's per kg. And so if we're kind of walking through it, we're doing 64 times 120. So we get that number. And then our tidal volume, if we're doing 7 cc's per kg, so that's 7 times 64. So their tidal volume is 448. And then we're dividing that by the minute ventilation. So it's 17 for a respiratory rate. Does that make sense? And that's really important because oftentimes patients will be hypoventilated, and that's kind of based off of when we think of our ACLS and when the advanced airway is placed, and you're breathing, you're bagging them at 10 a minute, once every 6 seconds, whatever, that's fine as an adjunct. But then when you get them on the mechanical ventilator, they need to be achieving this adequate minute volume, and their respiratory rates are notoriously, they're going to be 17, 18, 20, and that's okay because that's what their minute ventilation should be. Notoriously in the past, when what you'd see in an ED is someone they wouldn't calculate vent settings. There'd be a tidal volume of 500, a respiratory rate of 12, and they'd be on AC, and that would be it. And that's really harmful to patients. And that's why we're calculating our respiratory rate off of what the minute volume should be and what our tidal volume is based on ideal body weight. So that's done out there. So the FiO2 is going to be really important because oftentimes you'll go to a facility and you'll see them on an FiO2 of 100%. That's really dangerous, really because of hyperoxygenation and free radical production. We're titrating our FiO2 based off of our PaO2 over SpO2. Your intubated, ventilated patient should never have an SpO2 of 100. The reason being, if they have an SpO2 of 100, it means that, yeah, all of their hemoglobin is saturated, but they could have, based on the curve, they could have a PaO2 of 80, or they could have a PaO2 of 400. You just don't know. And that large amounts of oxygen are physiologically damaging to the patient. So high amounts of oxygen too are going to displace nitrogen from the alveoli. So when we talk about, you might have heard the term intrinsic PEEP, and that's the natural physiological PEEP. PEEP is peak end expiratory pressure that we have in our lungs. So nitrogen is really dense, it doesn't dissolve as well, and it almost acts like a pillow. So that's the PEEP that occurs naturally. So a high concentration of oxygen are going to bind to the nitrogen, create NO2 that's going to dissolve in the bloodstream. You're going to get rid of your auto PEEP, and it's going to actually sometimes collapse our alveoli. So it's really important that we're delivering as low as an FiO2 as possible to oxygenate our patients. This is used in conjunction with our PEEP. So PEEP is what's going to help keep the alveoli open. FiO2 is the oxygen that's help there for diffusion. Rebecca wants to see the formula. Which formula do you want to see, Rebecca? Here, I can unmute you. Go back. Oh, sorry. I'll let you
Okay, sorry. Go back again.
go back in. Yep.
This one right here. You lost me on that one.
Oh, yep. Okay, so that's our. Right here. We're calculating our minute volume. So that's how much volume the patient's receiving in a minute. So we're using our ideal body weight in kilograms times 120 cc's per kg per minute. And we get that number 120 because when we're normally breathing, and just right now, our rough minute ventilation is we're getting about 60 cc's per kg per minute. But when we intubate them, we're putting a tube down their throat, we're adding a vent circuit, so we're increasing the amount of dead space. So the amount of area that there's no diffusion, there's no uptake of oxygen. So we need to double what the requirement is. So when we do that, their new minute volume becomes whatever their weight is times 120. So that's what they should be getting over a minute. We already know whatever our calculated tidal volume is. So that's how much they're getting with each breath. So if we divide whatever they should be getting in a minute by the volume that they're taking with each breath, that gives us how many times a minute they should be breathing.
Okay.
Does that make sense?
Yeah.
Because it's the same thing if you just reverse the formula and you knew what their respiratory rate was and you knew what their tidal volume was. If you just multiplied that, then that would give you their minute ventilation.
Okay.
Cool.
Cool.
Cool. The two things that would change your FiO2, which would be a little bit different, is your pregnant patient. That's because there's two of them. So you're basically treating an increased amount of hemoglobin. So it's okay if they have a higher FiO2 for a little bit longer. So you want to treat them aggressively because you're treating the baby with that. So short-term high FiO2 is okay. Same thing with your trauma patients. They're going to be, especially if they're bleeding, you have this hypemic hypoxia. So less hemoglobin, there's decreased carrying capacity. So you really want to optimize their oxygenation as much as possible. And there's other things that you can do with the vent to do that we won't really go over. PEEP and FiO2 are used on a scale. You can think of, PEEP and FiO2 could almost be, if there was an option, one button on the vent, because they're always used in conjunction with each other to optimize that oxygenation. And we talk about alveolar recruitment. It's, getting alveoli available for diffusion. And that's what I alluded to earlier in the talk with the clamping the ET tube when we're transferring onto our vent. We think about things like driving pressure, and driving pressure is the initial pressure that we have to overcome to open the alveoli. And the best analogy to this is blowing up a balloon. So when you initially start blowing, it takes a lot of effort and then it becomes easier to blow more and more. But as soon as you let go and it deflates, it takes that same amount of effort to get back over again. So if they have them on the hospital vent, and they've been recruiting all this alveoli, and then all of a sudden you DC the vent circuit and you move them over, it's the same thing as letting that balloon go. You lose a lot of alveolar recruitment. So the solution to that, and that's why we have the hemostats with our vents, because before you DC their vent circuit, clamp the ET tube, DC their vent circuit, attach yours, and then unclamp. And you're going to help retain all that alveolar recruitment. It's really important because it takes a lot of time to get back what they lost. And older RTs, or more so nurses, will freak out when you clamp an ET tube, but the reality is they're not breathing anyway. So you're not doing really much harm. You're actually helping them quite a bit by clamping that tube. So the obstructive strategy, it's 8:24. So not something that we're going to go over too much in depth. Really, when we think of asthma and COPD and these pathologies, it's an exhalation problem. Because of the way they're breathing, they're not given enough time to exhale. So you get this air trapping, which is overall harmful. It's increasing intrathoracic pressure and it's damaging to the patient. So the solution to that is you need to give them more time to exhale. And the way we do that is a little bit higher of a tidal volume and a little bit lower of a respiratory rate, but not something we need to go over too much. That injury pattern is more important. This is the video part. Let me just get that 1 second. Sorry. Sorry. Okay. Can everyone see this video? Cool. So we've gone over everything as far as calculating vent settings in the presentation. So we'll just do an example now so you can see actually hitting the buttons on the ventilator. So as an example patient, we'll do a patient who's 5'10" and say 220 pounds of actual weight. And I already pre-did the conversion, so their ideal body weight comes out to 73 kilograms. So the first thing we're going to do is calculate their tidal volume. We'll do it off of 6 cc's per kg. So that just comes out to multiplying that by their ideal body weight, 73. And we got 438 cc's is going to be their tidal volume. So the next step is going to be calculating their respiratory rate, and to do that we need a minute volume. So like we said in the presentation, their minute volume is going to be 120 cc's per kg per minute. So that times 73 gives us a minute volume of 8,760. And then to get our respiratory rate off of that, our minute volume is our respiratory rate times our tidal volume. So we take our minute volume of 8,760 and we're going to divide that by 438. And that gives us a respiratory rate of 20 per minute. So then we look at that too, when we look at our I time, our respiratory cycle is going to be, if we're breathing 20 times a minute, 60 divided by 20 is 3. And if our inspiration is 1 second, our expiration would be 2 seconds. So that's an IE of 1 to 2. The FiO2, we'll just say stock standard, their ABGs are fine, FiO2 of 40, and same thing with PEEP will be 5. So the important things we have here, we're not going to change our I time at all. Our tidal volume is 438 and respiratory rate of 20. So these are the numbers that we want to plug into the vent. So, sorry, I think the video is a bit glitchy. We'll just do one more here. If it's glitchy, someone just tell me or text me. But this is actually pushing the buttons, which is a bit more important. So try this one. Later, because this is something that the paramedic doesn't have to do. This is something that can be going on while vent settings are being calculated and helping to expedite getting the patient out of there, because this is generally going to be a relatively critical patient. So it's pretty intuitive. One of the few things on the LTV that is intuitive is these connections. So there are ports right here, and these are super important because these are our pressure transducers. So not that it matters, but white is the high transducer, yellow is low. and then that's the exhalation valve there. But generally all of our alarms are, this is one of the first things you should check is these connections for your low pressure, high pressure alarms. Just because of how they twist on, it's easier to do the middle one first, I find. So it's pretty self-explanatory. Yellow goes to yellow, so that twists in there. This white has threading on it, so that goes into the white one. And then the last tubing here just plugs in. And then the only other thing we're connecting is the breathing circuit itself, which makes sense because it's the largest diameter. And that slides right into there. So now when we turn our ventilator on, right away the most important thing to find is the silence button. And it will ask you at first if it's the same patient. So when we talk about kind of when we select things, this is our knob for changing. So we'll go to new patient, select, adult, select. It's going to be on low O2 pressure because I'm not going to connect it to oxygen because we don't want to waste the tank. But we're making sure that we're connected here and obviously going right into the wall with that quick connect. So when we're selecting and changing any of our settings on the ventilator, we use the mnemonic where we push, turn, push. So we want to put our tidal volume down to 438, and we'll round up to 440 because we're in increments of 5. So I push the tidal volume, it highlights it, and then I'm changing with the knob, and then you need to push it again to confirm. So same thing with respiratory rate. We're selecting the respiratory rate. It's the only one that's highlighted. We're going to increase that to 20, and then push it again to confirm. We're going to leave our I time at 1, and we're going to change our FiO2 to 40. And we said we're going to put our PEEP at 5. So we have all our settings in there. So we want to have our ventilator settings preset. We'll be all set with our circuit. And this adapter here that comes in the packaging is really great because when we think about this, it's not very pliable at all, so it bends and pulls on the ET tube. So this helps prevent any crimping of the tube itself. So same adapters, so when we put it in the test lung, we should be all set here and seeing our volumes. So when we look right here too, these are our airway pressures. So that's our peak inspiratory pressure. So we're just over 30 there, which is okay. And like we were talking about, the most important pressure on our ventilator is our P-plat. And our inspiratory hold button is right here. It's not going to do it with the low O2 pressure alarm, but what I would do is when I see the inspiration, I'd push, and I would push it once and then hold it in on inspiration. And it's going to give me a number here on the bar, but then it's also going to say P-plat with a number there. And again, we want that under 30. And that's it. Okay. So let's go back to this. Cool. So real quickly, I know that we're over an hour now. Sorry, we might just have to go over a tiny bit if that's okay with everyone. Because I want to go over the non-invasive, which we'll use a bit more pre-hospitally. So CPAP helps oxygenation, but can be detrimental to ventilation. It's not as comfortable for the patient because it's one continuous pressure. It's great for your issues of pulmonary edema because it helps stenting those alveoli open. BiPAP is what's going to maximize that alveolar recruitment and their comfort because it's 2 levels. So you have an inspiratory airway pressure and you have an expiratory airway pressure. It's initially not very intuitive to how to set it up, but once you do it a couple times, I think we'll just do like a quick cheat sheet so you can just look at it. It's not as complicated as it seems. So your IPAP is your inspiratory positive airway pressure. So we think of something as type 2 respiratory failure. We're thinking about a ventilation issue, or type 1 is an oxygenation issue. So if we're increasing our IPAP alone, it's because they can't ventilate. It'll help blow off CO2. It'll help improve their tidal volumes and their oxygenation. If it's more of a pulmonary edema issue, we're going to increase our IPAP and our EPAP in conjunction. And that'll help force fluid out of the lungs, increase our mean airway pressure. And to improve patient comfort, we don't want to be increasing these pressures too rapidly. We'll do them in small increments. The trick to BiPAP is the pressure support. So I'm actually just going to skip ahead here. So you see this button, pressure support. That's because there's no IPAP button. So the IPAP is whatever number is in your pressure support plus your PEEP. So if your PEEP right now was set at 5, your IPAP would be at 15, because we have a 10 in here and we see centimeters of water plus PEEP. So 10 plus 5 is 15. Most of the time, and that's what it means by an additive ventilator, because that's how we get our IPAP. I'll go back to CPAP really quick. So to set it up, this is CPAP or BiPAP. We're hitting NPPV. You hit that button 4 times. I have another video that we'll go over this very briefly. Go to the pressure setting. So you hit that choice because it's going to default to volume. You move pressure support to those dashes because it's not BiPAP, it's one continuous pressure. And then you select your PEEP. Put that to you starting at 5 or whatever is appropriate for the patient, and then your breath rate you select, and that goes to the dashes as well. So once you touch the ventilator and do this, it's not that complicated. You can actually do it relatively quickly, and it works really well. Especially being able to use BiPAP pre-hospitally, it's generally a better and more comfortable option for your patients. So setting up the BiPAP, same thing, except you're setting that pressure support to get your IPAP, and you're going to set a backup breath rate at whatever is appropriate for the patient. So, sorry. So we'll go over kind of how to connect the ventilator, because this is something that the paramedic, sorry, wrong video. Actually, that should be the right one. Give me 1 second. Sorry, guys. There we go. I had too many windows open. Yep. All right. So we'll do CPAP first, because it's a few steps and it's easier sometimes to see how it works on the ventilator as opposed to just those written out steps. So same thing as if you're setting up the vent, you're going to change it to new patient, adult. So now we're in here. So what we want to do is we're preset on assist control. So you're going to hit this button 4 times to get down to the NPPV, so the non-invasive positive pressure ventilation. So 1, 2, 3, 4, we're highlighted there. And then we're going to change volume to pressure, which is hitting it twice. So we're all set there. Since it's CPAP, we're not going to have any pressure support, so we're highlighted here. That's going to go down to the dashes, and you hit it again to confirm. Start our PEEP at 5, or whatever is appropriate for your patient. And then the biggest thing too to remember with CPAP is our breath rate is going to be down at these dashes again because it's one continuous pressure. So the changes that we make with BiPAP is we want to create an IPAP, so our inspiratory peak airway pressure. And like I said in the presentation, the LTV1200 is additive. So you can see right here, it says centimeters of water plus PEEP. So if we wanted an IPAP of 10, we have our PEEP of 5, so our pressure support is also going to be 5. So that right there is an IPAP of 10 and an EPAP of 5. And because it's bi-level as well, we just want to set a backup respiratory rate, so that's whatever a normal adult respiratory rate is generally fine there. So split the middle. And then an FiO2, that's where, so if you're a really hypoxic patient, you can increase this up to 100 or 80, whatever you feel, titrating based off of your pulse ox at that point. And that's CPAP and BiPAP. Okay. So the alarms, kind of lasting for a couple quick cases. The high pressure alarm is what you'll see generally. Like I said, check your connections, make sure there's not a kink in the tubing, or they could be coughing, or there are increased secretions. Do you need to suction? Is your PIP elevated? And that's all those things. And when we think about our PIP, so our peak inspiratory pressure, and that's that when you see the bar going up and down with each breath, the one that it ends on, that's your highest pressure. And And when we think about how inspiratory pressures work and just the lungs as a whole, it's a lot easier to push air through a tube that's 3 inches in diameter than 1 inch in diameter. So if you have someone who's a severe asthmatic, they're going to have naturally high PIPs because you're trying to move air through a smaller tube, right? So we can change our tidal volume, because when we think about pressure, if we decrease the volume, we'll drop pressure, or how fast the breath is going. If you're trying to push something in really fast, that's also going to increase pressure. But generally, if you see a high pressure alarm, look at the connections, make sure the tube's not kinked, and if both of those look okay, then maybe we need to drop our tidal volume a little bit. Okay. Low pressure, same thing. The solution to most ventilator alarms, initially start at the vent and work your way towards the patient, make sure that everything is still attached, make sure the ET tube is not disconnected, there's no leak in the circuit. Or sorry, start at the patient, work your way towards the vent. You can also get a low pressure alarm with low minute volume, but it's not as common. So case number 1, you're sent to Franklin to bring a patient to Concord. It's a 46-year-old female. She's 5'7", weighs 210 pounds of actual body weight. She was in a snowmobile accident, has a uterine rupture and a splenic lac. Vital signs on arrival. She's sinus tach at 112. She's 82/38, setting 100% on the ventilator, breathing 24 times a minute. You have an end tidal 49, GCS of 3, because I like to intubate. Your vent settings on arrival, they're on assist control with a tidal volume of 550, a respiratory rate of 12, FiO2 of 100, PEEP, and a PEEP of 5. All right, we can toggle back and forth if you want to see it again. So they were intubated 1 hour prior to your arrival, 7.5 tube, 22 at the teeth. That was confirmed with chest x-ray and end tidal. The ABG you get is a pH of 7.38, PaCO2 of 37, bicarb 25, and a PaO2 of 212. They were given etomidate and sucks for the induction. And for medications, they've gotten 2 units Paxils, a gram of TXA, and they're on propofol at 20 mics per kg per minute. So what changes do you think you'd make based on these vital signs and their vent settings based on this patient and their size? Or what looks abnormal? What's concerning? If anyone wants to speak up. So they're really hypotensive, right? That's an issue off the bat, and they're on a propofol infusion. The vent rate is set to 12, but they're breathing at 24, so they're over-breathing the vent. They're tachycardic. Their FiO2 is at 100, and they've been intubated for an hour. On their ABG, their PaO2 is 212. That's very high. They've only got the 2 units Paxils, the TXA, and the propofol infusion, so their pain hasn't been controlled. And this isn't an uncommon scenario that you'll see here. So, their tidal volume needs to be changed. That's a really high tidal volume for a patient that is 5'7", 210 pounds. They meta-calculated that based off of 210 pounds, but off their ideal body weight, they're actually only 61 kilograms. So, even if you're going to 8 cc's per kg, their tidal volume at a max should be about 488. And then off of that minute volume, the respiratory rate should be about 15, which makes sense. So, and because of that too, their FiO2 needs to come down as well. They have an elevated PaO2. They've been intubated for an hour and their FiO2 is at 100. That's just really poor patient care. They're over-breathing the vent, so we need to take care of their pain. They need they need fentanyl, Dilaudid, whatever the ED is going to give you. Obviously, en route, we're going to be using fentanyl. And they're hypotensive, so they really need a change in that sedation package. They could be bleeding, and even more so, that's a reason to not be giving them propofol. You're counteracting what you're trying to do with your Paxils. So this is absolutely a patient that I would consider switching to ketamine and adjusting their vent settings. So. So case 2, you're going to Lakes for a 48-year-old male, 80 kilograms ideal body weight. They're intubated and they're going to Dartmouth. They're intubated for suspected DKA and decompensation. Their ABGs, pH 6.96, PaCO2 of 18, PaO2 of 76, and a bicarb of 13. Labs, just really simple chem panel. The concerning number there is your K of 2.1 and your glucose of 611. So their vent settings here. The big thing I want to take away on this is the respiratory rate. Generally, we're not going to be taking the DKA patient that's intubated because it's intubating a severe metabolic acidosis is a huge rabbit hole, and they always try to avoid it for one particular reason. So if you look at their respiratory rate is 16, but F, so remember we said F is how much they're breathing on the vent. That's what it shows up as. F is frequency. So they're actually breathing 38 times a minute. So they're over breathing the vent by 22. The tidal volume, and it's 500, PEEPA5, IDE 1 to 2. So if we review our ABGs, this patient is in a pretty severe metabolic acidosis, which makes sense with their DKA. They're later stage because the K is so low as well. So you get a K of 2.1. So initially in our DKA patients, we're going to see that initial increase in potassium. And as we have the increase in prolonged diuresis, they're going to pee that off. So they'll become dangerously hypokalemic. So we go back to here, we're looking at a low pH. The PaCO2 is low as well. That's because they're compensating. So they're trying to blow off that acid and they've already blown off a lot of it. And their bicarb is low as well. So if we're matching our pH decrease to our bicarb decrease, we have a partially compensated metabolic acidosis. They're very difficult to manage, and the reason being, when we talk about DKA, we see Kussmaul's respiration, so those really rapid, really deep respiration because they're trying to blow off all those ketones, right? They're trying to blow off the acid. That's why we're seeing the low CO2 at that point. So this is where it gets dangerous, right? If you set them at a low respiratory rate, they're going to be hypoventilating for their pathology. So say you put them on that respiratory rate of 15 or whatever, 16, whatever you had them on, but they're actually breathing 38 times a minute, you're going to start to see an increase in their CO2, right? When we're hypoventilating, we're increasing our carbon dioxide. There's a pretty neat formula that you can look at where an increase in carbon dioxide it has an inverse relationship to our pH. So as carbon dioxide increases, our pH decreases. So say you continue these vent settings, so they're being hypoventilated pretty significantly, and that CO2 goes up to 38, and you're saying, great, I have a normal end tidal. That's really not ideal because that is a pH initially of 6.96, and if we're working off that formula, you're going to drop into 6.8, and we're already super low. So that's why these patients are super difficult to manage on the vent. They always try to avoid intubating the metabolic acidosis patient because of the multitude and myriad of issues that can arise from it. But the biggest thing to remember if this does happen is that it's okay for them to have respiratory rates of 38, 40. That's totally normal on these patients because they need to maintain their compensation with that tachypnea. And the way they do that is they double the minute volume. So the cool thing too that you can remember is, if you don't have an ABG going out the door, because our sending facilities are sometimes notoriously bad at repeating ABGs. They'll do their initial and then not get it back. Your end tidal CO2 is actually always going to be within 3 to 5 of your PaCO2, and the PaCO2 will always be the higher number. So if you have an end tidal of 30, then their PaCO2 is going to be somewhere between 33 and 35. So that's kind of a neat trick as well. You don't need the ABG to see their PaCO2 en route. So that's something to keep in mind. Case 3, last one here. We're dispatched to Spear, God help us, for the transfer of a patient in CHF to CMC. It's a 78-year-old male. He's 5'10", 200 pounds. He's on a nasal cannula at 4 liters per minute. They've given him 3 rounds of 20 milligrams of Lasix and put him on a Bumex infusion at 1 milligram an hour. You listen to his lungs, you hear crackles bilaterally, there's perioral cyanosis, pedal edema, pursed lip breathing, and he's speaking in short sentences. He's sinus tach at 132, normotensive, 85% on that nasal cannula and breathing 30 times a minute. The kind of obvious answer here is that the diuresis is not working in managing his CHF, so we need to use a form of positive pressure ventilation. So we're going to use BiPAP here. And initially, when you go to a facility, BiPAP. Even if you're taking someone who's already on BiPAP, the standard setting is going to be 10. They'll say they're on BiPAP at 10/5. That means their IPAP is 10, their EPAP is 5. So on our LTV1200, what that means, just refreshing it again, is you're setting the PEEP to 5 and the pressure support to 5, because the IPAP is the pressure support plus the PEEP. So something to keep in mind. And like I said, it's difficult because the LTV1200 isn't the most intuitive ventilator to use, but it's just kind of practice and repetition and going over all this stuff. Those are my references, basically, mostly Scott Weingart's podcast. I highly recommend you listen to those. And then Eric Bauer's ventilator management, pre-hospital perspective. That's kind of all I have for everyone for tonight. I know that was kind of a lot, and there's a lot that we went over. I was talking about maybe making a cheat sheet that we could put through the vents, but I think the best thing is really the next time you get on a truck to play around with the test lung and work off of these settings and things that we went over so we can become proficient in it and try to provide some good patient care. So, any questions, or obviously you can always talk to me on shift or text me or email me. I'm happy to go over this anytime you want.
Tim had to go on a transfer, and he's wondering if he didn't go on a transfer. He went to cover. Tom's on a transfer. He wanted to know if you could write out the formula, because his brain couldn't catch up with what you were saying when you were going through it.
Definitely, I can do that. Do you want me to do it right now, or do you want me to draw it and send it to him? And also which formula?
Yeah, I think probably he's not on right now, so probably write something up, just walking through the steps of how to calculate.
Okay, cool. I'll do that and get it over to him. I think what I'd really like to do is just to make a sheet that goes with our ventilator transfer sheet that has how to calculate tidal volume, minute volume, respiratory rate, and what the norms should be on it, and how to CPAP, everything, maybe like a little booklet that just goes in the vent that's really short, sweet, to the point. You don't have to think too much about it. And then we can kind of simplify this as much as possible and get the data that we're looking for.
Is there an app for those, figuring the ideal body weights?
And there's a couple.
Critical's great.
What is it? Sorry?
I've used Critical before, just named Critical. It has a whole vent. Plus it also has other values and
Critical.
Hey, Bob, as soon as you and I start walking around Golden View, we'll be at our ideal weight.
Yeah, I'm still trying to figure out what Teslas have to do with vents.
Well, we'll talk about this at Golden.
Oh, test lungs.
Yeah.
I thought it was a Tesla.
MD Calc is also a really good app for a different formula, and it's a free
Which
app.
one is it, Bob?
MD Calc.
Okay.
That's a really good one. It has all those different equations and stuff. All right. Does everyone hate me? Are people pissed off?
No,
No,
you did
you
great.
made a really
Thank
good
you.
point that people need to put their hands on the vents and use them. And that was kind of the drive to do the vent checks. When I do them, whoever's my partner, get out here and we're going to go through this, because they can set a lot of it up for us.
Yeah, and that's huge. And I think I know Rebecca had expressed interest and really wanted to be here tonight. Because that's, if you're not touching it and doing those connections, especially as a BLS provider, it's really intimidating, the ventilator, touching it or moving it. And it's something that can be helping facilitate the process if they know how to set it up and
Hang it on the wall.
hang it on the wall. Yeah, I mean, I think the hardest part of the LTV1200 is mounting it back on the ambulance. But
I
Well,
think
I
a
think
class
this is
on ABGs would be good too, because I feel like at least a lot of people like you get told the ABG by the hospital, but like don't really understand what it exactly means.
yeah, that's definitely something I think in the future we can do. Cool. If no one has any other questions, so I think, Evelyn, can we do an hour and a half of CEU for this?
Mhm.
So that's good. At least get another half
Absolutely.
hour.
I think an hour and a half actually rounds up to 2 hours.
Or is that,
think it does
where's
too.
the calculation for that?
It's somewhere in your vent training. I think you just missed that slight part.
I think it's somewhere
Well,
in that
it-
roster we're gonna fill out.
Well, it's a Sunday, so it's time and a half.
Oh yeah, here comes.
We don't get that ER money.
That's the union guy talking right
There
there.
you go.
Gotta have a-
You said there's a quiz afterwards, so that takes up the half hour.
Oh,
There you
see,
go.
he's right.
here
Yeah,
goes-
we have a quiz
Yeah,
or
no,
some
it's gotta
shit
get
like that.
Yeah, it's just so it's on when you log into Vinyl, everyone's favorite website.
Because it works so well.
It's it's under education.
Sorry,
at
everyone.
the bottom.
Nothing against you.
Wait, I thought
Um,
someone was printing out CEUs for this, like on
Jesus
a.
Christ, he showed up on camera.
Oh, just for a minute.
Look at him. Holy shit.
I thought someone was printing out CEUs.
Evelyn's going to.
All right,
I
that's
think
perfect.
Todd.
No,
Stacy will be signing them.
Okay.
yeah, anything that you guys do from here moving forward, we'll have Stacy sign them because Todd's super busy with the strike team. So anything you and Evelyn put together for training, it's all approved by Stacy, and she'll sign them so we make sure we have certificates for everybody moving forward.